This is one of a series of 8 films featuring some of the early pioneers of quality improvement in the NHS, who share their personal stories and the practical wisdom gained from leading improvement when it was still a niche activity. The idea for the films was originally conceived during a conversation between Peter Wilcock and Helen Bevan about capturing the legacy of early improvement leaders, and it was given life by the publication of the National Framework for Action on Improvement and Leadership Development. I've been privileged to have met all of the leaders featured in this series of films early on in my own improvement career, and so I found it fascinating hearing their reflections as they look back on their experiences. We hope that their stories will make a powerful contribution not only to those of you implementing the new national framework, but to everyone aspiring to improve healthcare. What for you was one of the defining moments that got you involved in improvement work?
Well, I suppose, going back a long way, I never really saw that that was what I would be doing. I was very happy being a doctor, very happy being an academic clinician, and that would probably have been it. But there was one Friday afternoon, it always is a Friday afternoon, 5 o'clock, when a consultant colleague at another hospital phoned me up to ask my advice on whether a patient of his should have adjuvant chemotherapy for breast cancer. And this was a 32-year-old lady with breast cancer, so I asked all the obvious questions. Had the cancer spread to the lymph nodes? What was the cancer like under the microscope in terms of the grade of cancer? How large was it? And the fact was that they didn't remove lymph nodes in that city. They didn't record what the grade of the cancer was. They hadn't recorded how large it was. So on all of those questions, I realised that they just didn't have the information they needed to make a rational decision. And there was I working in a relative ivory tower. I had all that information. My job was easy. So I gave advice on what it should do, but it made me think, I wonder whether that's going on around the rest of the country. And so I then embarked on a research programme with the Thames Cancer Registry, first of all, and found, yes, it was. This was not an isolated case. There were real problems. And that made me feel, well, should I just stay in my ivory tower, seeing a few hundred patients a year, or should we try and do something about this? And could I have more influence by going more widely? And I talked to colleagues who were in an organisation called the British Breast Group and said, I think we need guidance on this, and we need guidance on the value of specialist teams. They said, Mike, you'll never succeed. And I thought, well, that's enough to make me really want to do it. And it was the best guidance document I've ever written. It was written by committee, but by fax in those days, not even electronically. I don't think we had one single meeting, and we published it in less than a year. But that really got me involved in saying, we've got to do something about the variation in quality that we see in this country. That was in one condition, but it was the condition I knew about.
Okay. And what was some of your key learning from that very early work?
Key learning was to look and see, is this a problem on a wider scale, or is this just one individual who's been badly treated? Finding out from that. Second key lesson, I suppose, was to work with colleagues on this. As an individual, I was not going to be able to make a difference to cancer outcomes in this country, but I could work with other experts. And I suppose part of that was about building a movement for change. And I think that has been a hallmark of other things I've done subsequently.
So in 1999, you were asked to become National Cancer Director. Can you tell us a bit about what that involved?
Yes, I can tell you a little bit about how it came about in a way. I think because of my previous experience of trying to improve breast cancer, I had then got involved in developing guidance for different cancers. And I think with the Department of Health, they either bring you in because you're a troublemaker, or they spit you out because you're a troublemaker. And in my case, they said they had decided that They wanted to make cancer a top priority, and that was a Prime Minister, Tony Blair's decision, and they suddenly realised maybe they actually needed somebody who was practising as a clinician to lead that movement. So that was very definitely about building momentum for change. There was a lot of feeling amongst cancer clinicians and amongst patient groups that things were not as they should be. There was an evidence base that was growing about our survival rates being worse than other countries. And people wanted change. There was a real drive for that. And so to get that change, I knew that what we needed to do was to have a national cancer strategy. But the first thing was I needed to persuade the powers that be, including the Prime Minister, that that was the right way to go.
Was that hard?
Actually, no, it wasn't. I remember having a one-to-one meeting with Tony Blair, and in practice what he was doing was acting as a barrister, really testing out whether I was a credible witness. If he decided to have a national cancer strategy, was I going to be able to take this forward, and how convincing would I be, I think. And so he asked 5 questions. Are cancer outcomes in this country as bad as people say? Why are they so bad? What are you going to do about it? How long is it going to take? And fifthly, what's it going to cost? I think I got the first 3 questions right. I grossly underestimated how difficult it was going to be to make the change, and also what it was going to cost.
And so what did you do about it? What were the key things that you put in place?
What we did, again, I come back to this business of building a movement, working with a whole range of different people, working with clinicians, working with cancer charities, with trusts across the country, a lot of different people, building networks so that at local level there was action going on as well as at national level. But then also giving people a framework, saying these are the things that we really need to concentrate on, whether it is early diagnosis is a big issue in cancer, and focusing on that, focusing on measurement so that we actually knew how long it was taking for people to get to diagnosis, focusing on making sure that there were teams in place across the country. Believe it or not, you know, only back in 1999, most people with cancer were not being looked after by recognisable multidisciplinary teams. That has changed very, very substantially since then. So those were some of the things that really did move forward, I think, as a result of having a strategy.
And I know that one of the key aspects of the strategy was the setup of these cancer collaboratives. How were quality improvement skills and methods built into those?
Well, this is one of this is the time when I first met Don Berwick and really came across that approach to improvement methodology. It was also interesting. That was true for an awful lot of clinicians. And I remember the first feedback meeting we had with Don, where I think it was 9 different clinical groups came back with what they had done in the first few months. What really I remember from that was the fact that they were applauding each other for making improvement changes. I've been to countless conferences where staff get applauded for some phase 2 clinical trial which probably has no long-term impact at all. But the idea of applauding people for making improvements in care, that was the first time I'd come across that. And that must have been in 2000 by that stage, I suppose.
So what are you most proud of achieving during that time?
I think the thing I'm most proud of achieving is building a movement for change and setting a direction and getting people to come with that, because no one person can improve cancer outcomes in the country solo. This was an effort from hundreds, if not thousands of people, and working with the National Cancer Action Team, with the Cancer Services Collaboratives, with the cancer networks, all of that, to get people, broadly speaking, pointing in the same direction and measuring the same things, doing the same things, improving care. And that has had a real impact on cancer outcomes for patients, both in terms of survival and in terms of their experience of care.
And are there any particular personal challenges for you in that role as National Cancer Director, and how did you deal with those?
Oh, I think there were probably plenty of personal challenges, but again, once one's dealt with a personal challenge, it's a bit like when you do A-levels, O-levels suddenly seem very easy, and whenever the next challenge comes along, the previous ones seem easy. But I mean, most of the challenges are getting people to do what you think is the right thing at the right moment. And sometimes that includes ministers. And sometimes what's really necessary there is to get different people coming from different angles, all roughly speaking saying the same thing to ministers, so that they aren't just listening to me, but they're listening to other voices and coming to the right conclusions. One other thing is that with any movement, there are lots of different parts to that and lots of different things one's trying to achieve. With cancer, there are lots of different cancer types. There's prevention, there's screening, there's early diagnosis, there's treatment, there's recovery, there's the care for the dying, all of those things that need to be thought about. But you can't do everything at the same time. So it's how you prioritise within that while keeping everybody pointing in the direction and feeling that change is being achieved.
So as such a major enthusiast for improving cancer care, what prompted your switch to the CQC?
When the report by Robert Francis came out in February 2013, it was very clear that the major problems at Mid Staffordshire had been exposed, but the question was, do those apply elsewhere as well? And the government response to that for Francis report was, or the initial response was largely, we need a chief inspector of hospitals. And I thought about it and I thought, well, maybe what I had learnt from the peer review program that we'd set up in cancer, maybe that could be extended in a different way and applied across the whole of the hospital sector. And I felt that would be a challenge, and it would be something that I would enjoy doing if they would have me.
And in your role as Chief Inspector, you've had the opportunity to observe a wide range of different NHS organisations. What are some of the key lessons that you've learnt around leadership and improvement?
The first thing that we've learnt at CQC through the new inspection programme is what wide variation there is within the NHS. There are some fantastically, spectacularly good hospitals and good services within the NHS. There are some that are frankly rather the opposite of that. And the key factor in whether something is outstanding is the quality of the leadership within that organisation. Have the leaders got it? You know, do they know where they're trying to get to? Are they passionate about it? Can they engage their staff? Can they effectively build a momentum within a trust to improve? Have they got the strategy about how to do that? And so they know the mechanics, if you like, of how to do it. Can they be tough when they need to be tough? But at the same time be supportive to staff the rest of the time. And the best leaders have that in spades. And one of the things that I've also noticed is that the best places don't talk about engaging clinicians. They talk about being aligned with clinicians, because what they are aligned around is better patient care. And where that's what can bring clinicians and managers together, putting the patient at the centre and saying, we know we've got limited resources, but how can we do the best possible job we can for patients? And that's what then works.
So what's helped you keep personally resilient on this journey from jobbing oncologist through to a major lead on improvement through to your role in the CQC?
I've had the most fantastic and varied career. I've loved, I think, just about, well, every part of it, if not every moment of it. When I was a practicing clinician, I could never have imagined giving up being a practicing clinician. And so the leadership journey came as a surprise to me. That was not part of my career plan at all, but I have thoroughly enjoyed it. I've enjoyed the intellectual challenge of it. I've enjoyed the working as part of teams, whether that's in cancer or whether that's at CQC. I've enjoyed communicating about it, so I get a lot of job satisfaction from it, as well as there being hard times. I think working with wonderful people, and I have done that both in the cancer role and here at CQC, people who are passionate about improving care for patients, people who put the patient at the centre, and that's what gets them out of bed in the morning, that knowing that there are going to be tedious meetings, difficult meetings, whatever it may be, but ultimately it is putting the patient at the centre, knowing that we could all do a better job for patients. That's where the resilience comes from. And I also enjoy getting away from it all. I tend to retreat up to Scotland in the summer, and I've got a cottage up there, and I climb hills in Scotland as a very good way of unwinding from everything that I'm doing at work. I can switch off really quite quickly when I get there.
So it's now recognised that developing a culture of continuous learning and improvement has to become core business for the NHS. As one of the early pioneers in improvement work, what would be your key advice for new leaders?
I think my advice to new leaders would be, first of all, go and observe what established leaders are doing. Go and learn from the best. One of the things that the CQC programme is doing is showing people where the best places are. There are some really wonderful leaders, those who've already got to outstanding, but also those who've taken a trust from inadequate to good. That's a huge achievement in itself. So go and learn from the best, because by and large they've got a lot of common characteristics. Focus on two areas. The culture, the organisational development. You can't do it without having the staff on board, as well as on what the specific improvement methodology is, whether that's Lean or Six Sigma or whatever. I personally think is less important. I think it's important to have a methodology, but that has to go alongside what you're doing to improve the culture of an organisation. I remember Claire Paniker, the chief executive at Basildon, on the day that her trust came out of special measures and was already good. I remember her saying, you see, we have nearly 5,000 staff in this organisation. Almost all of those are the same as when we went into special measures. But now we're getting the extra discretionary effort from them.
So if you could put yourself in a time machine and go back 25 years and give some advice to your younger self just starting out on your improvement journey, what advice would you give yourself?
Well, the first advice I'd give myself is go for it, do it. I think a lot of the time for doctors, you know, there is this view of those who can do, those who can't administrate, and I'm glad I ignored that particular piece of advice. I've had a fantastic journey of leadership, and so I would have just encouraged myself to go for it, encouraged myself perhaps to be even bolder along the line. But in essence, just do it.